Morning, everyone. We'll just wait a minute or two for some more folks to join us. So I think we've got a quorum, team. Should we get going? Renira et al.
I think we're good to go. Stephanie?
Okay. Let's get started. Well, good morning, everyone. My name is Peter Szatmari. I'm a child and youth psychiatrist, and I'm also the director of the Cundill Center for Child and Youth Depression at the Center for Addiction and Mental Health. I want to welcome all of you to the launch of this project that we've been working on for a number of years and that we're really, really excited about, our online tool for the treatment of youth depression. Next slide. So this is the outline for the day. I'll have a couple of comments as intro. Then we have a lovely poem and a live demo, not light, but a live demo. We'll talk about youth engagement in the project and then some contributions from our panelists, which I'm very excited about. Next slide. I don't think I need to remind people in the audience what a public health challenge child and youth depression is. This is a common disorder of children and youth, roughly 10% of the population in Canada and globally. Kids with depression face many different barriers to accessing care. Unfortunately, the response to treatment is only around 40%, much too low. You know, the health field wouldn't tolerate that response rate if it was diabetes or if it was leukemia. Again, even though that response rate is low, many kids who are in treatment drop out of treatment before it's completed, and roughly another 50% go on to another more severe episode. So depression is a recurring disorder. There is a long-term impact on education, on occupation, and on adult mental health outcomes. And there have been no new significant advances in treatment in over 40 years. Next slide. The Cundill Center for Child and Youth Depression focuses on developing best practices for the screening, prevention, and treatment of child and youth depression. We aspire to have a global impact on research, care, and knowledge exchange in this field. So we think of ourselves as having three pillars or three parts of the triangle. We conduct research to generate new knowledge on these topics. We then share that knowledge in an active way through our knowledge translation and exchange program. And with our global partners, we try and engage in a leadership way to improve best practices for child and youth depression globally. Next slide. Today's activity is an example of what we're doing with knowledge translation and exchange. It's well known that this is a key issue because there's been described that there's a 17-year gap between research that's conducted and confirmed in a university setting and the extent to which it's implemented in practice and has an impact on population health outcomes. So knowledge translation is a dynamic and iterative process that includes the synthesis, dissemination, exchange, and ethically sound application of knowledge to improve health, provide more effective health services and products, and strengthen the healthcare system. So one of the important activities that the Cundill Center engages in is the development of clinical tools to disseminate, to share, to support best practices when it comes to prevention, treatment, and screening for child and youth depression. And this online tool is one of our favorite examples. I'll pass it on to Renira at this point. Thank you.
Thank you, Peter, for our introduction. Before I get to my poem, which I've written, I want to acknowledge everyone that has contributed to this tool. So this slide will come up again during my poem, but it comes up really quickly. So I just want to take the time to acknowledge everyone from our center, from the Provincial System Support Program, our web designer, Chase, who I think actually might be with us today, and the Youth Engagement Initiative supported by the Margaret and Wallace McCain Center for Child and Youth Family Health and the Child, Youth and Emerging Adult Program at CAMH. So now I'm going to summarize our entire project in about 3.5 minutes. I know some of you may have already seen this video, so if that's the case, I hope you don't mind listening to me again. How many adolescents in Canada do you know? Put 25 in a room and almost 2 at some point will show major depressive disorder. And when this happens, we've got to treat it pretty soon. But the problem is there's this giant waiting room and the kids are not getting in. Tap, tap, tap. Do you hear that drumming on the door of primary care? It's knuckles knocking on wood, wishing there's hope in there. It's the kids, it's youth, it's parents, it's all of us coming to that first door, hoping it's enough, but it isn't always. Some family doctors will tell you they really don't feel prepared to manage mental health concerns, so they refer to higher levels of care, to pediatricians, to psychiatrists, you know, the ones whose appointments can be a little more rare. And all this results in that wait for mental health care. Look at our study of Ontario. Services differ depending where kids go. And don't ask me if all these services are evidence-based because, well, I'd have to say no, but we could say yes if we find evidence-based practices to treat and assess, if we build primary care capacity to do their best. This was our quest. Build a brief interactive online tool for primary care providers from east to west. Outline evidence-based practices for youth depression that are the best. Step 1, systematic review. Look at all the clinical practice guidelines out there. Rate the quality, compare, choose the best one, read over 200 pages, then step 2, strip it bare. Develop a skeleton, make a decision aid, work with clinicians to contextualize for primary care. Step 3, make the tool. You'll need 1 instructional designer, 1 web developer, 3 youth advisors, your subject matter experts, and me, a knowledge broker. And that's it, you're prepared. It was actually a bit more complicated than that, but click, click, click. Can you hear the sound of a mouse navigating our online tool? 4 sections, 20 minutes, and you'll be through. You'll start with the overview, learn basic depression facts if this is something new. If not, that's cool. Jump to assessment review, watch our simulation video, and check out assessment tools. And then the biggest part of it all, the treatment pathways, the reason we've been called. Click on mild, click on moderate, severe. There are 2 pathways with pop-up boxes to make everything clear. And finally, our resources, practical tools we've made with youth and clinicians by joining forces. Clap, clap, clap. Can you hear how excited we are about this tool? Do you wonder how you can access it? Are you feeling fueled? Go to our website or drop us a line. The tool is free and it's just in time because tap, tap, tap. I can hear the knuckles knocking on wood, wishing there's hope in there. The kids, the youth, the parents, all of us coming to this first door. I hope one day it's enough. So thanks for listening to my poem. I hope you enjoyed it. And if you didn't, I promise it's over now. You would have seen some pieces of our tool in the slides, but Stephanie and I are actually gonna take you through the tool. Actually, first, Sam, I believe we may have some questions for the audience. If you want to bring up our poll, there it is. I hope you can see it pop up on your screen, and I'll just give you maybe 30 seconds to answer the poll. Great. And Sam, can we share the results with the audience? Okay, there they are. So we're not actually going to tell you the answers now. Instead, Stephanie and I are going to jump into our demonstration. And if we do a good job, the answers should make themselves apparent. So Stephanie, most of the time you are the Associate Director of the Cundill Center, but today you are, for the next 15-20 minutes, you are actually not. Please tell us who you are.
Today, I'm going to be playing the role of Dr. Ameis, a family physician.
So Dr. Ameis, how long have you been a family physician?
I've been in practice for about 10 years. Please call me Stephanie.
Oh, thanks, Stephanie. Do you see a lot of young people with emotional and behavioral concerns?
I do. I see a lot of young people, especially more recently, more anxiety, more depression coming through the door.
And how do you know what to do when the young person comes into your office? Like, how do you approach the assessment and treatment process?
Well, I think we all do what we think is best, what we've trained to do. But I do think that depending on what physician a young person might see, they might have a different experience and they might get a different array of offerings depending on who they see.
Would it be helpful to you if there was a guideline that was based on evidence, something that was so easy that you could share it with your colleagues and they could follow a similar approach?
Something quick and easy that would be a reference, but yeah, I mean, that would be great, but does such a thing exist?
Well, yes. Haven't you heard of the Cundill Center's online tool for the treatment of youth depression?
Not until now.
What? You haven't heard of the Cundill Center online tool? Oh my gosh. Who is in charge of promoting this tool? It must be that knowledge broker, Renira Narrandes, fired instantly from the Cundill Center. But anyway, let's not worry about her. I am here now. And if you bear with me a moment, I am going to show you the tool. So, Stephanie, can you see the screen?
I can now. Yep.
Okay, excellent. So this is the Cundill Center online tool for the treatment of youth depression. You can go to cundilldepressioncaretool.camh.ca, and don't worry if you don't remember that, I'll show it to you again. You would begin simply by clicking the button that says begin. So here you'll see an overview of our tool. It's some basic orientation. If you didn't attend this webinar, it would orient you to our tool. We link to the clinical practice guidelines here that the tool is based on. In the next section, we provide some basic facts on depression, which you're probably already familiar with. You may be more interested in the third screen here, where we have a depression fact sheet that has actually been co-developed by young people on our team. So if you click this, you can download the fact sheet, you can print it out, or you can even just send the link over to young people in your practice. It's free. You don't need to be in our online tool to access this. You can actually just use this link at any point.
Wow, you mean that youth actually contributed to some of the content of this tool?
Well, they didn't just contribute to it, they did most of the work. In fact, remind me to talk about youth engagement a little bit later. So now we're in our assessment section, and here we provide a definition of depression and also allow users to review the DSM-5 criteria.
Well, that's really handy. So if you forget something, it's right there.
Yeah, and we really wanted it to be handy, just one click and there you go. And in the next section, we have a video that we actually developed in partnership with our young people. It takes, it's a primary care provider who's meeting with a young person and assessing for depression. Whoa, hold on a second. Am I seeing double, or do you have a twin or a doppelganger or something?
That's freaky. I don't know.
This is very frightening. In fact, let's click next. Let's let our young people tell you about the video.
Please,
so here we've got, sorry?
Please move on.
Okay, yes, I was also frightened. So here we have our tips for assessing depressed youth. We recommend assessing the young person's social network, working with them to identify what treatment outcomes are important to them and what treatment goals they have for themselves.
Oh, and I see you have a list of when you should refer on to specialty mental health services. That will be very useful in my practice.
Great, I'm glad you find it helpful so far. Here we have some more assessment pearls on how to set up a comfortable environment for the young person, as well as some reasons why depression might be missed in teens. And finally, we have some tips on how to assess for complexity and risk. So important to ask about alcohol and drug use, as well as experience being bullied or abused. Also very important to assess for safety due to the risk of self-harm and suicide. Next, we have some assessment tools. Do you use any assessment tools in your practice?
I do use some questionnaires. I don't use them all the time, and I'm not sure if they're the best ones.
Well, here we have a couple that we recommend. When you use questionnaires, do you use them to help you monitor changes and how the young person is doing?
I'm not sure. What do you mean exactly?
So if you repeat the same questionnaire over the course of treatment, it can help you track whether symptoms are changing, in addition, of course, to using your own intuition as a clinician. And then you might be able to spot changes earlier and make changes to treatment. And make changes to treatment if necessary. This is called measurement-based care, but don't worry, I'll show you what I mean when we actually get into the treatment pathway. Oh, I see that we're almost at the treatment pathway. I'm wondering, Stephanie, do you have a young person in your care who we might be able to test this out on?
Yeah, I did see a young person just yesterday, 16 years old, who I think does have depression. We can call that young person Charlotte. Charlotte's really not doing well. Charlotte's grades have dropped. They're not texting their friends as much anymore. They've even lost some weight and aren't sleeping well. They have little energy.
Oh, I'm sorry to hear Charlotte isn't doing well. It seems like it might be severe depression. So on the screen, you'll see we have some information that can help you determine whether it's mild, moderate, or severe. I'm going to click on severe for now because it sounds like it is. What do you think?
Well, she does meet criteria for depression, and the symptoms that are present are substantially in excess of those required to make the diagnosis. So based on that, I do think it makes sense to call it a severe case presentation.
Okay, so now that we know it's severe, let's go to the main part of the tool that I wanted to show you, the treatment pathways. We've got two treatment pathways here, one for mild depression and one for moderate severe depression. As you know, young people present differently, and so there are different recommendations for different types of presentations. Since Charlotte likely has severe depression, let's look at the moderate severe pathway. So we would suggest referring Charlotte to a youth mental health specialist, but we know the wait list can be long. Is that the case in your practice?
Yeah, it can be about 6 months or so. Renira, can I ask you something? In my screen, I see a little black box. I don't know if others people see it, but I wonder if it's where all of our pictures are coming up. Is there any way to move it?
I've just moved it. Thanks for letting me know, Stephanie. Is it gone now?
It's gone. Yep.
Okay, well, you can't use the tool if you can't see the tool, so I'm glad that's gone. Anyway, we were talking about how long the wait list is.
Yeah.
And whether that's the case in your practice.
Especially lately with the pandemic, it can be even longer. It's at least 6 months or so to see a mental health specialist, a psychiatrist.
Well, we know that's the case. We would still want to start treatment right away while Charlotte is waiting. The first step would be to talk about lifestyle advice and psychosocial strategy. So I'm going to click on that button there, and you can see we have evidence-based guidelines on things like exercise, sleep, diet, some information on anti-bullying. And here you can see some of the resources that we've developed for young people. We have a couple of animated videos and a package. I'll actually show that to you when we get to the resource section. Oh. Since her depression is moderate severe, we know from the evidence that starting her on medication plus psychotherapy will likely be best.
But I see it says, that if a young person's not agreeable to medication, that you should just start with psychotherapy. Is that right?
Well, it's true. Some young people might not be open to medication and some might not be open to psychotherapy. It's important to work together with the young person, but we do recommend the medication and psychotherapy stream for Charlotte or for other young people with moderate severe depression. So if you click on that, you'll see you'll be given separate recommendations for medication and psychotherapy. I'm going to click on the medication tab and show you that. Fluoxetine is recommended as the first line medication. Do you know if Charlotte has already tried it?
Charlotte hasn't been on any medication for any mental health symptom.
Okay, then we recommend trying fluoxetine first. If Charlotte doesn't respond to it, you could try sertraline or citalopram. And you can see here we provide titrating, monitoring, and tapering information for all three of the medications.
Oh, I love how all of that information is laid out there step by step.
Good, I'm glad. We also want to highlight that medication should not be offered without also offering psychotherapy, though we recognize that different services vary in their abilities to provide psychotherapy. If psychotherapy is declined, the young person should still be offered medication. I know it'll be Charlotte's first time on antidepressants, so I wanted to show you this handout that you could give to her. This handout has been developed by young people on our team, as well as with a psychiatrist and a pharmacist. It explains in very simple terms to young people what antidepressants are, when they might know that the medication is working for them, what some of the side effects can be, as well as some tips to try to mitigate that.
Oh, that's wonderful. So I can give that to Charlotte so that she can be part of the solution in terms of if she's feeling anything, she can kind of come up with some ideas of how to mitigate some side effects. That's wonderful.
I'm glad. And in terms of what psychotherapy you might want to offer Charlotte, if we click on that, you'll see that we recommend trying individual cognitive behavioral therapy first, if that's possible. But if it's not possible, you could try one of these: individual CBT, interpersonal psychotherapy, family therapy, psychodynamic therapy, or care management problem solving. I do want to let you know, though, that the psychotherapies for the moderate severe depression stream are different than the ones from the mild. I'm not going to show you the mild stream yet, but or today, but if you wanted to look at it later, just click up here and then you can toggle between the two pathways.
Fantastic.
So after 4 to 6 weeks, you should check to see how Charlotte is responding. So we'll click on that. And there's 3 things that you really want to look at here. Your own clinical judgment would be one of them. The assessment tool that you would have used earlier for the initial assessment would be another. Do you remember when we talked about measurement-based care?
Yep.
Yeah, so you would repeat that same questionnaire here and then look at the results to see if things have changed. And then the third thing that you would want to consider is how Charlotte is doing with her personalized treatment goals.
But how do I know what a response is?
Well, you can check out our definition. So if I click here, you'll see that we have defined things like response, partial remission, and full remission. Now, if Charlotte has responded, you would continue the treatment for 3 months. So let's click on that. And then you would check the response again after 3 months. It's the same process. You consider the same 3 things. And then let's say that after you do that, you see that Charlotte is in remission, then you would continue the medication for 6 months, develop a relapse prevention plan, and reduce the intensity and frequency of the visits with Charlotte. So if I click on this box, you'll be able to see some things to consider when developing the relapse prevention plan.
I can see that.
And that's it. That's one example of how you can make your way through this pathway. But of course, there's obviously different pathways included in here.
Wow, I love how it's all laid out for me and it's there in a stepwise fashion. How long would it actually take me if I wanted to go through the whole module to make sure that I knew what I was doing in terms of providing evidence-based care for mild or moderate severe presentations?
Probably just about 20 minutes. It's actually not that long.
That's pretty good. Okay, so I can fit it in sort of half of my lunch. That's great.
Yeah, I'm glad you like the pathway. That was really what we were hoping for. There's one more thing that I want to show you, but I'm just a little bit worried.
What are you worried about?
Well, I think that you're going to be really annoyed.
Why would I be annoyed?
Well, okay, I'm just going to show you. You see this little clipboard here in the bottom left?
Yeah.
And it's also on our mild pathway. Let me just show you. This is our mild pathway. It's here too. So if you hover on this, we've got a question for you, and we hope that you'll answer it. It's one question. Will you implement any new practices based on this tool? Just takes a second to answer. And then if you're feeling really generous with your time, we really hope that you will click on this survey, and I'll click on it for you, where you can let us know what you think about the tool. I mean, it says 5 minutes, but really the survey will take you like 3 minutes. 5 minutes is if you really wanted to contemplate every single word in the questionnaire.
Renira, why is this part really important? Why is it important for me to take the time to give some feedback?
Well, because we hope that we can improve this tool. So if there's something that isn't working, or if you have a really great idea, if there's something we're missing, we really want to know so we can improve this tool and improve the experience for all primary care providers. We really want to be providing the best care for young people possible, and that's a collaborative effort.
All right, that makes sense. I'll do it. What about the resources? I don't think I saw that part.
Oh, I completely forgot. Thanks for reminding me. So the final section of our tool goes through some of the resources that we've developed at the Cundill Center in partnership with young people, with primary care providers, with clinicians. The first section will show you some of our psychoeducational tools. These are 2 videos that were developed mainly by our youth team. The first one describes depression to young people in a way that's really easy to understand. And the second one talks about how things like food, movement, and sleep can have an impact on young people. These are actually really popular. This one here has actually been viewed over 30,000 times. It's been incorporated into the curriculum in schools in the US, so highly recommend these. In the next section, you'll see again, this was the depression fact sheet I showed you, but if you download it and scroll through, you'll see there's more tips on sleep, exercise, healthy eating. Again, this was developed by our young people in partnership with some of the experts at our center. Next, we have some assessment videos here that we've developed in partnership with primary care providers. The first one talks about why using measurement tools is important, how it can help inform care for youth. We talk about measurement-based care in this video. The second one is about one of the tools that we recommended, the RCADs. All of our videos at the Cundill Center are very short and very to the point, so it won't take you long. I don't think any of them is anything more than 4 or 5 minutes. Over here, we have a quick guide to the RCADs that you can download and look at. We developed this in case people had questions that weren't answered in the short video. Here we link again to some of the recommended assessment tools, the mood and feelings questionnaire, the revised children's and anxiety depression scale, and a standard set that has been developed by an international organization. Here you'll see again our medication handout that I told you about. Again, you can download it, print it, email it, whatever you want to do with it. Here is a video that we've developed for young people that explains what problem solving is and how it might be helpful to them. And here we have some worksheets. I'll just show you this one. This one is on problem solving. And we also have another one on cognitive restructuring. Here you can get access information that may be more local. If you click on crisis services, for example, you'll be redirected to a resource that outlines crisis services in the Toronto area and beyond. And finally, we have some crisis lines here for young people. So that is the tool. And we have some references if you're interested in that.
Wow, so that's like an entire package that helps to make sure that care is evidence-based and that you have really nice tools to engage young people for a family physician to use with their patients. That's amazing. Now, so I want to make sure I understand. Does everyone have access to these slides, this online tool? How do I get at this the next time I want to look at this?
Well, there's several ways. This is the actual URL, cundilldepressioncaretool.camh.ca. You can also go to the Cundill Center website, cundillcenter.camh.ca, where you'll be able to see the link to the online tool, and you'll also be able to access all of the other tools that I showed you. Those tools you can access on their own. You don't have to go through the online tool to access them. And you can email us at any time. We do respond to our inbox. It's cundill.center@camh.ca.
Oh, that's great. So the whole module, everything that you just showed me is available at this URL.
Yeah, correct.
Thank you.
I hope you'll use this tool, and thanks for giving me the 15 minutes to show it to you.
Fantastic. What's next, Renira?
Well, Stephanie, I think this concludes the live demonstration, and now Sam, I think we're going to bring up another set of polling questions, if you can do that. There we go. So just give people a minute or two to answer. Stephanie, I wonder if you, once the poll is done, if you want to talk through the answers for our audience.
Sure, I can do that. Just give me a cue when you want me to start.
Sure. Sam, I think maybe we can end the poll. Perfect. Okay, there you go, Stephanie.
Well, so it's wonderful to see that I'm thinking that our tool is useful and that it will be useful in improving best practices in the treatment of youth depression. So that's wonderful. We're so happy that this tool looks like it has a place and might improve care for the young people that we care so much about at the Cundill Center. In terms of our questions, so youth with depression should be given the same treatment options: medication, counseling, psychiatry, consult. So 71% of respondents said this was true, and 29% of respondents said this was false. I wonder if some of the wording here might have been a little bit unclear, because what we're saying in our tool is that we want care to be standardized, and we want there to be equity in care, so that if young people come through different doors in terms of getting service, that they get the same standard of care every time, and it's an evidence-based care approach. But there are different approaches that seem to be effective for different types of presentations. So we know that individuals who have mild presentations of depression, they don't necessarily need mental health specialty referrals. They can be treated right there in family practices, and sometimes in partnerships with community agencies providing the psychotherapy services that we recommend. And sometimes those individuals, if they don't respond to treatments, they might need a different type of approach. So moderate to severe pathway has different recommendations in terms of referring to mental health specialty care right away and offering both medication and psychotherapy. So we are recommending, based on the evidence base, that we provide different types of approaches that are appropriately tailored to the presentation. So for mild presentations, we don't usually offer medication. We start with psychotherapy first, but maybe that's because we didn't go through both the mild and the moderate to severe pathways to show some of those comparisons. Number 3, antidepressants are equally effective at improving depression symptoms in youth. So the evidence in youth depression suggests that across studies, when we look at efficacy findings, that fluoxetine overall seems to have the best evidence in terms of improving symptoms of depression. We don't only offer fluoxetine because not everybody responds to that medication, and there are other medications that also have evidence, but actually fluoxetine has the best evidence if you look across the literature. There are different kinds of psychotherapy options available. You could start with any of them and see how it goes. So 60% of respondents said that was true. 40% of respondents said that was false. There are, if you look at the evidence and the best evidence-based care guidelines, some differences in terms of what the recommendations are for different psychotherapeutic approaches. And so our guideline goes through that as well.
Thanks, Stephanie, for going through that for our audience. I want to now shift gears and talk about youth engagement in this project. And here I'm going to introduce to you a couple of our youth advisors who have helped us on this project. We have Zara Uddin with us and Melanie Asselin. So I'm going to start by just asking you, Zara and Melanie, why engage young people?
Oh, whoops, sorry. So while this tool is for clinicians, the overall outcome directly affects youth. So in that way, we wanted to ensure that the creation of this tool was a collaborative process. While the treatment of depression for youth will be collaborative as well, we wanted to ensure that this too involved youth input. So from there, we were talking to the youth team about different aspects of youth depression and about how they felt when looking at the tool. So of course, we wanted to ensure that we included the things that youth wanted their clinicians to know, and we included things that were relevant to youth experiences about depression. So in total, how could we ensure that youth and their clinicians could create positive experiences when seeking help for depression for the first time?
So how did we engage youth in this project? We were a team of 3 youth and 1 youth facilitator. Can you go back 1 slide, please?
It should be there now because there's just a bit of a lag.
Okay, perfect, thank you. So we reviewed the whole tool and we provided feedback to make it more effective for youth. One example of this is instead of saying treating youth with depression, we replaced it with supporting youth as they manage their depression. And in the later statement, you can appreciate that we're centering the youth as the primary driver in their care, whereas in the first statement where we said treating youth with depression, that kind of frames the physician as the treatment driver. And in depression, the youth is the primary driver because depression is such a complex condition and it can't be treated simply with prescribing antidepressants most of the time. So if you frame youth in the center, then they're better able to heal because they know what they need more than anyone else does. And after we reviewed the tool, we went to a youth advisory group meeting with 15 other youth, and we got their feedback as well on the tool, especially a video, which is on the next slide. So can you please advance? Okay, so this was the video that we actually took out because we didn't like it. Everyone in the youth advisory group of 15 youth, they all really disliked this video. And there are a few reasons for this. I will highlight a few. So first of all, the social worker here who was assessing the youth, whose name is Tony, did not explain the confidentiality agreement. So she did not share that everything is confidential except in X, Y, and Z conditions. And in that way, she didn't make it comfortable for the youth to share as much as they wanted because then they know that this information is not getting shared with others with exceptions. And secondly, and perhaps most importantly, she really lacked in rapport building. So she did not introduce herself in the beginning, and she goes from one question to another without acknowledging Tony's points. And in this way, it seemed like she was asking questions from a checklist just to fill out a form, and it seemed very dismissive of Tony's points and thus unempathetic. So for example, at one point, Tony says that it's even hard to get up in the mornings. And then the counselor, she doesn't acknowledge this point and say how difficult it must be to not be able to get up in the mornings. And instead she jumps into asking if Tony uses drugs or alcohol. So she should have used more empathetic statements, more validations, more open-ended questions to allow for more sharing from Tony's end instead of closed-ended questions and more reflections. So that was heavily necessary, and that was what she was lacking in this video for sure. So we took this out and we made a new video to be a better example for physicians on how we would like youth to be assessed for depression.
So of course, we wanted to include a more positive example within the tool that exemplified what a more ideal interaction would look like between a family physician and a young person. So in this case, Dr. Stephanie Ameis was the family physician and I was the young person. So when we created this new video, we wanted to make sure we weren't making the same mistakes that the original video was making. That original video was developed by someone else and we just found it on YouTube. So we decided to take a bit of a more creative approach in developing our own. So it was important for us to have a good example of both client etiquette and proper language when going through our depression assessment with a young person. So we added information about the virtual context as well, especially because youth may have concerns about privacy and confidentiality, especially in our new context of doing a lot of doctor's appointments online. We also talked a little bit more about suicide and self-harm in this video. We included more open-ended questions, and we also wanted to ensure that the doctor and the young person had a bit more of a chance to build some rapport and get comfortable in the assessment before diving into some hard-hitting questions. So from there, we developed this tool, and our youth team agreed that it was a much better example of something to be included and something to be shown to family physicians when going through the tool.
Thanks, Melanie. So I believe you wanted to show a section of the video. Is that correct? I think.
Yeah.
Give me 1 second. I'm trying to stop sharing so we can all see it. Okay, I'm going to take you back into the tool and we're just going to show you the last maybe 2 minutes of the video so you can see some of the great questions that we added. So just give me 1 second. Please, someone let me know if you can't hear it or if there's something wrong with the audio.
I just want things to feel better again.
Melanie, would you say that you've lost interest or are getting less pleasure from many of the things that you usually enjoy?
Not as much. I just, I don't feel like I enjoy the things as much as I used to. Like I still like my friends. It's just not as much fun to go out with them anymore.
I'm sorry to hear that. Do you also feel like your thoughts are more negative or you're feeling down about yourself a lot of the time?
Not really. I just feel like I want things to be the way they used to be. I feel like I'm disappointing my friends and family all the time.
Sometimes when people are feeling really negative about themselves, they can also start to think things like they wish they weren't around. Have you been having these kinds of thoughts?
No, I haven't.
Melanie, have you been having any thoughts about wanting to end your life?
No.
Sometimes when people are feeling down, they may want to cause pain or injury to themselves without meaning to end their life. Have you ever deliberately harmed yourself in some way?
No.
It can be really hard to talk about these things, so thank you for your openness with me. I'd like to ask a few more questions to better understand how things have been going recently, and then we can talk about what might be helpful, including a note for school.
Okay, thank you.
Dr. Ameis continues the assessment, asking additional questions. Melanie.
So I'm going to stop the video there. And actually, I'm going to stop sharing everything now. Whoops. I think. Can't really see what's going on. Give me 1 second. Okay, there we go. That should work now. Thanks so much, Zara and Mel. You really have helped us a lot with this project and given us a lot to think about. At this point, I want to introduce the third member of our panel. I hope Dr. Euler is here. I wasn't able to see earlier. Oh, yeah, she's here. So Dr. Karin Euler is a family physician with the Georgian Bay Family Health Team, and she's the mental health physician lead over there. She's also a partner with us on a really exciting project that we've been working on for a couple of years now. I'm going to let Dr. Euler explain more about the project, but actually I'm going to hand it over to you, Stephanie, to facilitate the panel.
Sure, thanks, Renira. So before I hand it off to Dr. Euler, I would love to just hear a little bit of your impressions about the online tool. Now that you've sort of seen it presented in its entirety, Melanie, Zara, what do you think about it? Do you think it will be useful?
Right, so I can definitely speak to that. As a young person myself who experienced depression at a young age and began to struggle, and of course, like I didn't know what to do about it. So I went to go see my family physician, and coming from a small town, very rural area, there wasn't a lot of conversation about depression or about mental health. So even in my doctor's office, I could feel that there was a lack of confidence and a lack of security in terms of knowing where to go next when I, approached my doctor and said, hey, I'm feeling this way. So of course I was placed on a waiting list to a specialist. And in the meantime, I wasn't offered any sort of treatment. So in that case, now flash forward a couple years, well, many years, to now working on this tool, it's really a glimpse of hope to see that there are different options to educate clinicians and family doctors in order to provide the best first steps and the best next steps as well for helping youth manage their depression. As a young person, of course, going through depression, that's a challenge in itself, and that's a whole journey that can be very difficult and have a lot of different barriers along the way. So one of those barriers should not be, a clinician who doesn't feel comfortable or who doesn't feel like they have the proper information to send the young person on to the next step, right? So definitely looking at this tool, I feel like it is a huge step forward in terms of creating a universal care plan in Ontario for young people to help face depression and battle depression.
Thank you, Melanie. That is, it's really helpful to hear about your personal experience. And that is exactly the kind of situation that we had in mind when developing this tool, that it can take so long for a family physician to get their patients access to somebody with specialty training in mental health. And we really want those family physicians to be able to provide care confidently to the young people in their practice. Zara, what about you?
Yeah, I think this tool is a great step forward. I really echo what Melanie is saying. It provides evidence-based practices for physicians, and it's easy to read, easy to go through. Sometimes when you're looking online, it can be very difficult to navigate all the information out there, especially because youth depression, it exhibits a little bit differently than older people, adult depression does. So youth can be more irritable, whereas adults can be more sad. So it's important to have this tool so that all of this information is in one space and physicians are more easily able to navigate through it and provide the best care for youth.
Thanks, Zara. Yeah, I mean, it would be wonderful if through a 20-minute tool, we can really increase capacity and make sure that family physicians are on the same page to be able to recognize depression in youth, which can be hard to pick up on because of that difference in the mood presentation in terms of irritability as opposed to sadness. Dr. Euler, what about you? What's your perspective as a family physician?
Yeah, so we are often the first point of contact for young people when they're struggling. And I think typically in the past, we just did different things and we didn't really have any sort of evidence-based or streamlined approach. I think often family physicians are clipping along. They probably have 15 minutes for this appointment. They don't even know that it's going to be a complicated appointment. And then they think, oh, what am I going to do in 15 minutes? And sometimes the first response is, well, I don't know what to do, so I'm just going to refer them. And then this is terrible because the young person doesn't get any help. They have to wait sometimes 6 weeks, 3 months before they see anybody. So we definitely needed education. We definitely needed ways to help our youth in a better way. As I said earlier, in a family physician's day, you have a limited amount of time. So you really need to dial in on what is going to be the most useful and the most helpful quickly.
And so you're working at the Georgian Bay Family Health Team. Will you tell us a little bit about your experience with the sort of special implementation project that has been a partnership with Cundill?
Sure. So we saw a presentation by Peter. We were completely blown away by it. We loved it. We thought it was fantastic. And that was about 2.5 years ago. And we decided at our family health team that we wanted to do a similar thing, but we wanted to tailor it to the resources that we had in our community. So our family health team is 55 family doctors. We have 4 youth counselors. And then we have some counseling services in the community, New Path and KinArc and Catholic Children Family Services. We have a whole bunch of different resources, and a lot of family doctors, would just refer to our 4 counselors who surely cannot manage all the referrals coming in. And moderate to severe patients were being referred for counseling when really they needed more intense care. So we embarked on a project. We met every month for 2 years. We involved everyone involved. We involved the IT, our mental health counselors. We invited the community mental health service counselors. We connected with another service that became part of our pathway. And we tailored a algorithm that is easy for doctors in our family health team to just pull up on custom forms on their computer system and start working through the algorithm. And it's been really, really amazing. It just gives you everything you need for a mental health visit with a young person. So I do have it, I can share my screen, Renira, if you'd like, and just show what it looks like visually. So if I share my screen, let's see if this works. Is that working?
Not yet. There might be a few seconds delay.
Okay. Anything happening?
Not yet. Sam, does Dr. Euler have the co-host capabilities she needs?
Yes, she does. She should be able to share now.
Okay, so I hit share screen. Maybe I need to do one other step. Did that work?
Yes, there we go.
Okay, awesome. I think that was a problem at my end, sorry. So what you see in front of you is the algorithm that we're using. And I'm just gonna get my screen a little more organized here so that I can scroll a bit. So you can see at the top, you have, so what happens is you are clipping along in your day, and then you get a young person and possibly their parent in the room, and you just all of a sudden have to slow yourself down, go, okay, this is a youth depression or anxiety visit. But what you can do is bring up this tool and you can start clicking through it. And if you can see, I realized that I need to do some screening questions. So you just click a button and you can go ahead and date your screening assessment. You can work through the ARCADS, which we have learned is one of the best tools for screening for depression and anxiety. So you don't even have to sort out, oh, is this depression or is this anxiety? The ARCADS does it for you. So, and there's also an amazing tool that we incorporated into ours where you can screen the parent. So you could screen the parent with the child in the room, or you could screen the parent on their own. And then if you feel like you need to take a deeper dive into assessing suicide risk, there's another form that you can pull up about suicide risk and go a little bit deeper into the suicide questions. The other thing we incorporated into our algorithm was dates and times that we've done these questionnaires, because we're actually tracking progress of our patients. And so as you go along in the algorithm, you can see when these assessment tools were done. You can track the scores. You can see if they're improving. You can see if the strategies that you've implemented are effective. So that I really like about it too. Once you've done the ARCADS, which doesn't take very long, then it tells you where you're at. It tells you whether you've got anxiety mild to moderate, anxiety moderate to severe, depression mild to moderate. So it categorizes what is going on with the patient with you. And once you click on that, then a whole bunch of tools pop up. So you know immediately that evidence says that this child would benefit from both therapy and medication, but you think, oh my God, what medication do I do? What dose? I don't even know. Well, it pops up for you. And not only does it pop up for you, but once you decide you're going to do a prescription, it immediately brings up your prescription and populates the dosing and the increments for increasing. It's just so great. We also color coded it for what steps are for which people. So we involved our physicians and nurse practitioners, our Georgian Bay Family Health Team people who navigate the pathway. New Path is our services that are outside our family health team that we decided as a group would do the moderate to severe counseling, whereas our family health team counselors would do the mild to moderate counseling. And then the purple ones are the whole team being involved. We also decided at what interval we would like to be reassessing our patient, checking in with the ARCADS again. So you can also click on boxes and you can immediately print out resources for caregiver. You can show the video for child and youth depression right in the room with the parent and the child present, which is super useful. And you can watch it together. They can ask questions. It tells you which medicines, as I said. It also gives us at our family health team the option of doing an e-consult. Say we think this person is really complex and they seem like, okay, I don't know if just starting this child on Prozac plus doing counseling is everything they need. I have a couple of questions about this aspect of their depression. And so you can immediately click this box and you can do an e-consult that gets answered in 24 hours. So you can say to the family, you know, this seems a little bit more complicated. This is what I think we should be doing, but I just want to ask our local psychiatrist what he thinks or she thinks we should do for our next step. So I will get back to you in 24 hours with their recommendations. And that's been really useful to us. We have a particular clinician who is keeping an eye out for e-consults from our algorithm and answering them really, really quickly, and was fully involved in creating the algorithm. So the other important thing about that is that he was also getting all these referrals that were probably inappropriate, whereas we could have gotten youth started on their recovery journey instead of waiting to see him. So his wait list has decreased dramatically. And then we can get the more severe or complicated youth into him and get his wait list really reduced. So that's been really helpful for our whole process of providing mental health services to youth. So we can next we can decide who they should receive counseling from, and we can refer them to the Georgian Bay Family Health Team counselors, which would do our mild to moderate, or we can refer to New Path. And when you click on the button, it immediately brings up the referral form. You quickly auto-populate it. The referral is done. The patient then is contacted quickly to get into their counseling. And then as you go down, it tells you when we did that referral, when they're being seen. So as a family health team, we're also tracking how we're doing for receiving consults and when the patients are actually being seen and helped. And we can monitor these things, make improvements, look at our wait list, see what we can do better. So we wanted to incorporate some of those things. Then we have the person back. We know that we need to reassess and see how they're doing. So we decided as a team that would be at week 6. So we would repeat the ARCAD score. We can compare it with the previous score. We can decide if we want to continue with the intervention, or if the patient isn't improving, what are we going to do? So if their ARCAD score is worse or the same, we decide that maybe we want to have a team review. So we decide which of these interventions we would like to do to help the child and youth improve because they're not improving. And we can track which intervention we did and when we did it. Then we keep on moving down, we reassess the patient again. And we also are tracking when they are doing really well, when they're discharged, when we want to taper the medication. We have guidelines for how to taper the medication. We have information for a tailored relapse prevention program that we share with the youth. When we are discharging them from our care, we still want to make sure they're doing well, and what and when and how would they reach out for help again if they felt like they weren't doing well. The references are all here, and each button you click on gives you resources that you need. So that's like a quick and dirty kind of like how we use our algorithm and what we did, that it was different than sort of the Cundill's tool to just tailor it to our region. We're a rural practice, and so we don't have all the resources that that CAMH has. So I'm super proud of this. I'm super proud to be part of the project that did it. Our family doctors and nurse practitioners are using it now, and it's been really, really well received.
It's so nice to see that initiative being taken by your practice in order to sort of tailor and individualize the approach to what your everyday setting is. And it's amazing to see that a standardized approach then allows for individualized care to make sure that young people get the right care at the right time. if there are other family doctors who are watching, how might this process be translated to other settings? Dr. Euler?
Yeah, I thought you were asking the general population. So I thought you were asking other docs online how they would like to modify it for their area. I think if it can be totally modified, like we took the structure of the Cundills and then we just met, we decided what our resources are and what resources we wanted to use. And we made sure that those stakeholders were on board, could accommodate our referrals. So you can do anything. You can modify it any way you want. You could decide you don't want to use the ARCADs. You could decide that you want to use a different tool. You could, I think the place where it's most modifiable is what counseling resources do you have in your community? That's where you can tailor it to be very specific to your community.
Could other healthcare providers or family health teams get in touch with Georgian Bay to kind of get some pointers on how to personalize the process to their setting?
Sure, we have a whole team that was involved in this. And so I'm happy to take any questions about it. Anyone on our team would be happy to. You can just reach out to Georgian Bay Family Health Team, and we would guide you through what our process was like. It did take us a long time of meeting once a month, but I think now that we've done it once, I don't think it would take as long as it took us to do it. I think within a few months, you could have a really good product that would help your family doctors and nurse practitioners.
Thank you so much. All right, I think we are just about out of time. Renira.
Yes, we are. We're 8 minutes over time. I think Sam can stay, but I know a lot of other people may need to leave. So if we do this again, we may want to give ourselves an hour and a half in case people have any questions. But if you do have questions that we weren't able to answer, please email us, cundill.center@camh.ca. We can redirect you to the Georgian Bay Family Health Team as well. Thank you all for attending. Stephanie, I don't know if you have any last few words. Oh, I want to thank Sam and Shanique, who have been in the background running our event for us. Thanks so much for helping us with the event today as well.
And thank you, Renira, for getting our launch organized. It has been a long time coming to get this online tool out, and it's so wonderful to be able to share it with all of you and to share it broadly. Thanks everyone for joining us today, and we look forward to keeping in touch. Thank you for Dr. Euler, Melanie, Zara for joining us today.
You're welcome. And I put my email, the second email, in the chat if anyone wants to send me an email with any questions.